Treatment techniques for the foot and ankle. Now that we've learned how to evaluate for either a structural or a non-structural dysfunction, we will look at how to treat for those following situations. Remember, your patient will have dysfunction. We need to evaluate to determine whether it is structural or non-structural to determine the appropriate method of treatment. Let's review. When looking at a structural versus a non-structural dysfunction, remember that if the dysfunctional movement still occurs with passive range of motion, or when a person is being supported or taking gravity away, then it is a structural dysfunction. That means that an anatomical structure is physically blocking the motion. It's almost like trying to push against the wall. The wall is not moving. You will need to break through that wall in order to obtain motion. When we have a structural dysfunction, we will then treat with some kind of release technique. If the dysfunctional movement, however, disappears or changes significantly when passive range of motion or support is being introduced, then it is a non-structural dysfunction, meaning that there is no anatomical structure blocking that motion. And therefore, we would need to treat with a stabilization technique or go to the list of the reasons why we have non-structural dysfunctions in our patient, figure out what is the reason for our particular patient, and then treat appropriately. Again, structural and non-structural dysfunctions, determining what your patient is dealing with will allow you to treat the patient effectively. When you're not effective with your patient, you're probably treating the wrong thing. I'm going to review the reasons for a non-structural dysfunction because this is so important when you're treating your patient. The first potential reason is inflammation. And it doesn't need to be current inflammation or swelling that you can obviously see. It could be from an old injury or surgery, and this is where your subjective history is going to be important. Because for every cubic centimeter of inflammation, a muscle will shut down by 1%. So if there's any inflammatory process going on in the area, the patient is going to be unstable and have difficulty moving. Because again, you need to have stability in order to have mobility. If you have a patient who has an inflammatory process and a reason for a non-structural dysfunction, you will need to treat with anti-inflammatory type treatments, either medications, injections, acupuncture, other modalities that can deal with the person's inflammatory process. Then we need to look at alignment because alignment dictates function. So if the alignment is off, the muscle will not be able to contract with greatest vigor, again, going back to the length tension ratio that we have mentioned earlier. Does the patient have upper motor neuron disease or injury? Was there an old TBI or concussion or stroke or spinal cord injury in the patient's history? Or could there be a lower motor neuron injury such as neuropathy or an impingement of a nerve? Those too may cause non-structural dysfunctions in our patient, and we need to address them accordingly. The patient might have severe atrophy if they've been immobilized or in a coma for a long period of time. And lastly, there might be some psychological limitation due to a fear of pain or fear of movement or other psychoses going on. Again, it's appropriate to figure out what the reason is and treat it accordingly. Because if we're treating for inflammation and the person has a psychological issue, we're treating the wrong thing. Again, remember, if your patient is not getting better, you are probably treating the wrong thing. So before we get into treatment, we need to think about what our goals of treatment are. And primarily, the number one reason for treatment is to restore function. That's what the insurance companies are paying for. That's what the patient wants. They want to get better. In order to restore function, you need to identify the appropriate dysfunction that is causing the patient's limitation. Once you've identified it, that's half the job. Then you need to provide the appropriate technique for their particular problem or dysfunction that they have. It is only if you identify the appropriate dysfunction and apply The best treatment or treatments available to address that dysfunction will a patient get better and you will restore function. And the second goal of treatment is going to be to achieve carryover, to prevent this problem from happening again. How do you do that? Well, ideally, you can change the structure. And with the younger patients and even older patients, if you are a good manual therapist, you can do this manually. If not, you can also rely on things like taping, bracing, orthotics, those kinds of things to help achieve carryover. And lastly is to provide home exercise program and then ADL training. And if I had to pick the more important of the two, it would be ADL training. Because you could be working with a patient in your office, let's say they have back pain, and then the patient goes home and they drive 3 hours in the car in a bad position. They're going to wind up right back where they started. All your work is going to be for naught. So we have to educate our patients in exactly what to do when they are not in therapy, how to conduct essentially the way that they sit, the way that they stand, the way that they walk, the way that they run, those types of things to prevent a hindrance in their ability to rehabilitate. So what are our treatment options for structural and non-structural dysfunctions? For structural dysfunctions, remember, we're going to want to find the modality or treatment technique that is going to move an anatomical structure. So those would include ultrasound, massage, other types of soft tissue mobilization techniques, maybe functional mobilization, stuff that's used by the Burrell Institute. You can use stretching, chiropractic manipulation, heat, etc. Laser would be included in there as well. And some of the benefits is that these are the ones that are familiar to you. You might have more. ART is another one. Or on the con side, a lot of them are only appropriate for certain types of tissues. There isn't great carryover, and some of them are very time consuming, like ultrasounds can take a solid 10 minutes of your treatment time, and nowadays we just don't have that time. So I'm going to be introducing to you an alternative technique that I use and that we're going to be using in the class. For a non-structural dysfunction, you could do anything that restores stabilization. Remember, though, with a non-structural dysfunction, you need to identify the cause of the non-structural dysfunction to treat accordingly. But ultimately, the goal of restoring function when a dysfunction is non-structural is going to be to restore stability, because again, we need to have stability in order to have mobility. So appropriate modalities for stability would include Pilates, lumbar stabilization techniques, NDT, PNF, using the physio or BAPS board. Don't forget taping and bracing may also help to improve stability in certain patients. And again, the pros of this are that they are familiar. And on the con side, a lot of them are not very specific. So if I wanted to stabilize the big toe and I had somebody on a physio ball, I wouldn't necessarily be getting stabilization to that hallux specifically. Okay. A lot of these also require certain equipment, certifications, and they might be unsafe for certain populations, like getting a stroke patient on a physio ball. So again, we want to pick the treatment option that is going to be most appropriate for our patient, and bear in mind that the treatment techniques that I'm going to present might not be appropriate for your patient. So again, it is important to know what the dysfunction is that we are trying to address with our patients, and then apply the treatment technique that is most appropriate for that individual. The treatment techniques that I'm going to introduce to you in this class are two techniques that are used to treat structural and non-structural dysfunctions accordingly. The first one is active release with manual stabilization. I call it ARMS. And the ARMS technique is used to treat all structural dysfunctions, where the goal is releasing an anatomical structure that is preventing either quality range of motion or causing a compensation in a person's alignment. This technique evolved from Greg Johnson's functional mobilization technique. The second technique is called position of manual stability, or POMS. And that's used to treat non-structural dysfunctions once the cause of the non-structural dysfunction has been addressed. Because think about it, you can treat stabilization, which is what the position of manual stability will do, but if you never take away that inflammation, you're not going to gain carryover. So you need to address the underlying reason for the non-structural dysfunction and then use position of manual stability to get carryover with your treatment. And this technique evolved from PNF, developed from Herman Cabot and Maggie Knott. And it's modified from the technique in PNF called a prolonged hold. It's very similar to a prolonged hold. However, this technique is going to be performed not necessarily in the traditional PNF diagonals.